Okay, morning everyone. I might make a start now. Welcome to the Mobility in Falls Prevention webinar. My name is Balana and I am the Injury Prevention Officer for Workforce Engagement at Injury Matters. Before we begin, please let me acknowledge the Whadjuk Noongar people as the traditional custodians of the land on which Injury Matters work, and recognise the Aboriginal and Torres Strait Islander peoples' continuing connection to the land, waters and community across Western Australia and Australia. I would also like to acknowledge the traditional custodians of the land on which you are joining in from. Please use the chat box to let us know where you're joining in from. Before we start, I'd like to go over a few housekeeping points. You will notice your microphone is muted. This will allow all attendees to hear clearly. However, we would still love to hear your questions, so we strongly encourage you to please send them through in the Q&A chat box throughout the presentation and we'll go through them at the end. If you have more than one person in the room with you listening to today's webinar, we would appreciate it if you could please let us know via the chat tab to let us know how many people are listening in with you. If you face any technical issues during the presentation, please write them in the chat box and we'll do our best to help you. I have Tegan here helping me today. We will also have a QR code at the end of the presentation so you can complete a short evaluation on the webinar. If you could keep that in the back of your mind, that would be great. Please note that Injury Matters prohibits the use of artificial intelligence-driven systems and technologies, such as automated note-taking, recording, or transcription tools during or following this webinar. So, just about Injury Matters. At Injury Matters, our vision is for safer people and places. We aim to prevent and reduce the impact of injury within the Western Australia community and support those who have been affected by injury. Our three programs aim to raise awareness of injury risks, consequences and solutions, prevent injuries through a range of education and support programs, and support the recovery of people, family and communities impacted by injury and trauma. This training is brought to you through our Stay on Your Feet program with the support of the WA Department of Health. The Stay on Your Feet program provides information, training and support to older adult community members and professionals working with older adults on how to prevent falls in the community. Stay on Your Feet has three key messages that we use throughout our campaigns and community and workforce engagement. These three messages are move your body, improve your health and remove hazards. And this is where we get our overarching slogan, move, improve, remove. Falls are a significant public health issue in WA. It is seen that 1 in 3 people over the age of 65 fall each year. The 2025 WA Falls Report highlights that in WA someone dies every 17 hours, is hospitalised every 16 minutes and presents to the emergency department every 12 minutes due to a falls-related incident. Falls can result in a real impact on an individual's life that can lead to a loss of independence and confidence, increased concern of falling, and difficulty doing daily tasks. Our 2025 WA Falls report has recently been released. You can view the full report by scanning the QR code. Mobility is crucial for healthy ageing and falls prevention, allowing older adults to maintain their independence, participate in physical activity, and engage in social and community life, and access the necessary health and community resources. Functional mobility is multifactorial and is influenced by body function and structure, personal circumstances, and environmental factors. When mobility is limited, the risk of falls, hospitalizations, and reduced quality of life increases. This leads me to introduce our speaker for today's webinar, Meredith. Meredith is a physiotherapist with over 35 years of experience across several clinical areas. Since 2012, she has been a lecturer at the University of Notre Dame, mainly working in the Bachelor of Physiotherapy program focusing on gerontology. In 2018, she completed her Masters of Health Professional Education at UWA. Meredith has a passion for falls prevention, which led her to joining Injury Matters in June this year. I'll now pass you on to Meredith.
Okay, we're in the same rooms, so yes, there's a little bit of a shuffle there. So welcome everybody, and thanks so much, Balana, for your introduction. Now, I'll just make sure that I'm going to not be technically challenged. Okay, so it's my hope for this session that you'll have a better understanding about why functional mobility challenge is important, how to assess it, how to assess mobility, and the elements to consider when prescribing appropriate exercises and programs to prevent falls in the community. So I used 4 primary sources for this webinar to create the content for you. Firstly, the Australian Commission of Safety and Quality in Healthcare's best practice guidelines for falls prevention in the community. This was released earlier this year, and these guidelines come in 3 versions. So community care, which is our focus. There's also hospitals and also aged care homes. And the guidelines have a real intervention focus. I also used a systematic review by Kathy Sherrington and colleagues that informed the World Health Organization Physical Activity Falls Prevention Guidelines for older adults. Alongside that, the position statement by Anne Tiedman and colleagues on exercise for falls prevention in older adults in the community. And then also lastly, the World Guidelines for Falls Prevention and Management in Older Adults, led by Manuel Montero Dasso, that came out in 2022. All of these sources are freely available, and I understand that Balana is going to send you the links to these, and I highly recommend you taking a look at them. So I suppose, why present this topic? Well, when reviewing the new Australian guidelines, one key difference from the previous version published in 2009 was the inclusion of the word mobility in the exercise recommendations. So these exercise recommendations here that you can see here are based on Cochrane and systematic reviews that show with high certainty that ongoing exercise programs that include adequate balance challenge and functional mobility exercises, plus or minus strength, for 3+ hours per week, reduces falls in older adults by 42%. There's actually no need for any further research to decide whether exercise actually helps. It does help, and we need to get the message out there and be appropriately educating and supporting our older adults. And I suppose the thing here is that, are we adequately dosing and doing the right types of exercises in the right amount, and it being adequately challenging to really make a difference for falls prevention? So what's a fall? So this is the WHO definition, and it's probably something that you have seen many times, especially when it comes to falls prevention type webinars. But I've included it here because I really want to emphasize that any reason a person comes to rest unintentionally on the ground or a lower level is considered a fall. And look, sometimes older adults don't report the fall because they may dismiss it, like, oh, I slipped on that, slippery floor, so it wasn't really a fall, it wasn't really my fault. Or I slipped on the gravel, or potentially, oh, I tripped over the dog, or, oh, I was walking in the garden and I tripped over the hose. So I did fall over, but I wouldn't really say that, gosh, I've got to actually tell someone about this fall. Or, oh, I was feeling dizzy and my legs just crumbled beneath me. I didn't hurt myself. I didn't lose consciousness or whatever. I didn't black out. So I won't really talk to anyone about this as a fall. It's a bit embarrassing, just a silly thing that happened. But I think the really key thing is that history of falls and number of falls, especially in older adults, is such a key indicator of falls risk. So it's really important that we know what a fall is and that we are communicating that to our older adults when we're asking them questions about it. So that brings me to my next slide. So the recommendations from the World Falls Guidelines suggest that these 3 questions are included in all dealings with older adults, at least on an annual basis. So firstly, have you had a fall in the past year? Or have you fallen over? Again, making sure that they know what a fall is, because it's so important. Now, older adults, especially men, are often reticent to actually self-report unless they're specifically asked. And there's a recent local research that's shown that individuals of Chinese descent may not actually even disclose the falls, as it's considered bad luck that actually discussing it will cause more falls in the future. So the recommendation here is maybe approach the topic of falls sensitively. Ask the person to talk about what they know about falls, or maybe if they know anyone else who's had a fall, take that sort of softer approach. And that might be useful for a lot of our older adults as well. Secondly, we want to ask, do you feel unsteady when standing or walking? And then, do you worry about falling? Have you got any concerns about falling? Is anything stopping you from actually getting out there and doing things because you're worried you might fall? And if someone answers yes to any of these questions, so one of any of these questions, it really indicates that we should get out there and actually do more comprehensive assessment and treatment and interventions. Now, you're all here because you're interested in falls prevention. But how can we get the word out to our colleagues and even out to the community to ask these 3 questions of our older adults? Whether or not the older adult is seeking our help for falls and balance, try and make falls prevention part of our service to our elders. Okay. So I popped this up here. It's a little bit wordy, but I suppose this is indicating to you why falls reporting is so important. So both the Australian guidelines and the World Guidelines have created intervention algorithms linked to risk categories. And these risk categories are keenly linked to falls history, number of falls per year. So if we look at the Australian guidelines that came out in 2025, you can see here that their risk stratification is simply by number of falls per year. So this is why it's really important that we get our questioning and our definition of a fall correct. And you can see that there's recommendations at different levels: low risk, intermediate risk, and high risk. The World Guidelines also use number of falls, but add in more complexity about gait problems, whether it's severe fall or not, and other factors such as frailty, etc. So again, whether you're using the Australian guidelines or the World Guidelines, we really need to make sure that we're getting our information about falls history correct. So what's functional mobility? So it's multifactorial. It's influenced by health conditions, about impairments of body functions and structures, and also influenced by environmental factors and personal factors that can be all encompassing. We probably, if you're familiar with falls prevention, we know that there are intrinsic risk factors, there's extrinsic risk factors, there's behaviour type risk factors that come into play, and these all impact our functional mobility. So mobility is, I suppose, movement. It tends to be inherently associated with an individual's strength and balance from a physical perspective, and possibly you're all here because you want to influence that side of falls prevention. Function is, I suppose, having a function. Simply put, we think of standing up for a chair, getting in and out of bed, walking, stair climbing, and then other things like, activities of daily living like showering, toileting, gardening, cooking, all those types of things, shopping, doing all those things. That we need to be able to move in different directions and maintain our balance within and our centre of mass within our base of support as best we can. So in order to actually complete these dynamic movements, we need that physical capacity. We also often require cognitive capacity to complete the tasks. And I suppose while mobility and function are not synonymous, the influence of things like confidence, fear, self-efficacy, motivation, alongside sort of cultural and social aspects, they all have an influence over somebody's actual performance of these functional mobility tasks. It's important that we consider domains of function beyond the physical, okay? We often tend to focus on that, and I suppose this webinar will tend to focus a lot on the physical capacity of things, but really ultimately cognitive, emotional and social aspects of that individual have so much influence over how we perform. So we must make sure that we take the whole person into account to assist us when we're preventing falls. So look, I know many of you are here to understand how to embed mobility assessment and exercise into falls prevention. So I'm just going to talk a little bit about the connection between functional mobility and postural control. Okay, so balance control and postural control is a function of so many multiple systems relying on each other. The individual uses their sensory systems, so their vision, the vestibular system, the somatosensory system, to provide information to the central nervous system. The central nervous system then needs to integrate this information to process it and send out appropriate motor commands to the appropriate muscles. And then there's this continuous loop of new information generated by the change in our body structure, body posture, and also the external information that we're receiving. So firstly, we really need a well-functioning sensory system. Our vision, firstly, gives us clues and messages about the environmental challenges and also helping us to maintain our gaze so we can assist the equilibrium of our body. Our vestibular system helps maintain balance by detecting head movements and changes in position and giving us information about motion and orientation and spatial awareness. And then our somatosensory system providing skin sensation and proprioception information about body position. So you're all health professionals, you're probably well aware of all of those, but maybe not considering all of that when you're thinking about postural control and balance. So we've firstly got that sensory system, but then we need that central processing. It's really complex and it needs to be ideally very rapid. So firstly, the brain needs to prioritise or weight the sensory information based on the information that they're getting in. So for example, like if the lighting is poor, then the light's not been switched on, we really need to rely heavily on the vestibular system and the somatosensory system. And if they're compromised, then that's going to be a problem. They also need to use all of this information to prepare for functional movement. And the challenge that they've faced by anticipatory control, sorry, my words are stumbling, and using things like ankle and hip strategies. They need to prepare the head and the neck and the body position to make sure that they're maintaining gaze and they're maintaining the upright position and they're keeping their center of mass within their base of support. That's even before they actually start the functional mobility task. And then also for unexpected disruptions, such as getting knocked in the supermarket or a sudden change in level of the ground or the surface or some other tripping hazard. They need to actually also have some reactive control. These need to be of appropriate timing and they need to be of the appropriate force. And they're often things like the stepping strategy or the grasping strategy that we see. So we absolutely need a really well-functioning neuromusculoskeletal system. It needs to perceive the sensations, process the information, and complete the actions. And obviously, as we get older, we do find that there's more impairments and more constraints within all of these systems that then lead to increase of falls. Now, functional mobility really challenges all of these systems in a very rapid and ongoing way. And it's through a challenging enough functional mobility ability exercises that we can really challenge and work these systems to adapt and improve. All right, off my little information source there and on to there's some practicalities. So let's discuss ways to assess functional mobility using standardised instruments. Now, the World Falls Guideline that came out in 2022 recommends a couple of key tests that most reliably predict falls risk. Primarily, we use the 10-metre walk test. This is known as the best predictor, and it has its challenges. Certainly, adequate space is an issue when we're working in the community. Really hard to find 10 metres of flat, straight area that they can be used. But certainly there's also room for the 4-metre walk test to be aligned to also get a gait speed. Now, the gait speed that is considered to be a high falls risk is anything less than 0.8 metres per second. And as I said, the 4-metre walk test is also acceptable. And with the 4-metre walk test, basically the testing space is 4 metres and then we need 1 metre to get up to speed and 1 metre to slow down. So again, requiring a little bit less space. So if you don't have enough room for a 10-metre walk test, a 4-metre walk test is really great. Now, the second choice, or possibly used in conjunction, is the timed up and go. Something that you're probably well familiar with, a fairly simple test to do, doesn't need too much space, doesn't need too much equipment. Obviously, there's things like chair height and chair type that might be a struggle to get standardised, especially in the community. But this is a really important one too. And I suppose when we look at it and in regard to falls risk, there's an increased risk of falling if they get a score greater than 15 seconds completing this task. Now, this test is great because it's relatively simple, but it also challenges physical capability, dynamic balance in the transitions and walking and turning, and also our cognitive ability to understand the steps and to complete the task properly. And I have actually adapted this image here that I found online to make sure that we're well aware that when we're conducting this test that we are walking to the 3-metre point, turning around and coming back. We shouldn't have like a physical object that the person is walking around, especially they're going to take a lot longer to walk around that if they've got a walking aid of some kind, to a mark, ideally something, a piece of tape on the floor that they walk to, obviously of good contrast so they can see it well, and then sitting back down again. Okay, so some additional functional mobility assessments that you could use are the 5 times sit to stand and the functional reach test. Now, neither of these are reliably used as a predictor of falls, but you will see them commonly used. Again, we need to make sure that we are sticking to the protocols so that our outcome measures are reliable, that they're standardised, and that any normative values that we're using for these 2 tests are comparable to what we're actually doing. Now, they're both dynamic assessment items and they're much more related to functional movement than the usual static balance assessments, such as like the 4-stage balance test or the Romberg test. These both have their place, but when we're talking about functional mobility, we're thinking about dynamic movement, changing position. Now, a really good thing too about the functional reach test is it can also be used as a way of dosing our reach type tasks that we might be using for our for balance challenge. And then we come to some multifactorial functional mobility assessments. So firstly, the DEMI. Many of you are probably well aware of this. It measures and monitors mobility changes. Obviously, there's a lot of different items, some bed items, some chair items, but really from going from item 6 where we're sitting, item 5 where we're sitting, going from sit to stand, we are doing that dynamic movement that is in standing, that is linked to functional mobility for balance. The Berg balance is the gold standard, I suppose, for balance tests, and there's a combination of static and dynamic items here. Now, falls risk scores, I suppose, are unclear. I have this stratification of falls risk with the Berg balance scores. Other sources indicate that below 45 is actually high risk of falls. But really, the evidence is that it really shouldn't be used alone as a fall prediction tool. And I suppose then coming to actually evaluating those tests, I really want to impress that we want to evaluate beyond the times and the scores. While they're important to be able to track as an outcome measure, really observing movement, looking at the impairments and limitations that are evident when they're conducting and when they're actually doing the tasks themselves that are in the mobility assessments is really important. Of course, history taking to making sure that we are getting a lot of information about what type of mobility issues that they're having, what other constraints they may be having in their life and their environment, and making sure that we're attending to what the patient themselves wants and they're doing the goal setting, I suppose. And then obviously some cognitive assessments where appropriate, because ideally we want to make sure that we're giving them individualised, client-centred exercises and interventions at all times, where possible. Now, I don't want to underestimate, this is all linked to functional mobility. Obviously, we have very comprehensive screening and assessment tools that are linked to falls and balance, and the FROPCOM is one that you might want to take a look at if you haven't already. All right, so we've discussed what functional mobility is. We've talked about how it's linked to postural control and balance, maybe how you can assess it, I suppose, with that falls risk lens. What we need to know now is how do we embed functional mobility within exercise prescription, and so that we can actually reduce or prevent falls. And that's possibly what most of you are here to listen to. So hopefully I'll be able to provide some clarity on that. Basically, what I've got here is a list of things that come from this source here, the Exercise and Sports Science Australia updated position statement on exercising for preventing falls in older people living in the community, that was put out earlier this year by Anne Tiedemann and her colleagues. And I believe that this has informed a lot that's come through with the Australian World Guidelines and World Guidelines, not the World Guidelines, just the Australian Guidelines. So the points I'm going to discuss are basically a summary of the recommendations in this source that are linked to functional balance challenge. There's a lot more in there, so I really recommend having a look at it. So mobility, functional balance challenge must be in standing. Okay, we want to be working in standing, not in seated position. Obviously, we may need to work on balance and sitting to prepare someone to be able to take on standing challenges, but for it to be a balance challenge, it needs to be in standing. That's going to help prevent falls. We need to be moving, so it needs to be dynamic. So not those sort of static holds, but transferring weight, stepping, multi-direction. And that doesn't just mean forward, backwards and side to side. It means at all angles, at different levels and heights as much as possible. We need to aim for a narrow base of support. We also really need to aim for hands-free. Now, I do understand that when we're starting off and we're teaching our exercises to our people, that we may need to start with hand support in more static positions, but we really need to be pushing towards that hands-free, because we're really not challenging the individual in a balanced sense if they're holding on. They're not necessarily going to be holding on when they have a fall. So we really need to prepare them for that challenge of being hands-free and needing to be able to maintain their balance as much as possible. It must be moderate to high intensity, and I will be talking about this a lot more. I feel that we have a tendency to go too easy. It's really difficult to get that balance between what do we give to our clients and to the community, exercises that we feel safe enough for them to just go away and do. But maybe we're not really adequately challenging them to make an actual impact on their balance at all. Something is better than nothing, but we need to be pushing the intensity. They also indicate that in order to make the activities meaningful and specifically aligned to the task that person is going to have to do, we need to try and incorporate it into their daily living. This will, I suppose, not only help them to be able to get the right amount of exercise done and balance challenge done, 3 hours plus is a lot to get done in a full week. But if we're doing it consistently throughout our everyday life, it's actually easy. It doesn't take a lot of time. We also want to make sure that we're preparing them to actually be able to maintain their balance in the challenges that face them individually in their daily life. Now, also, we need to be including recovery from the floor using reverse chain. Strikes fear into the heart of any health professional, but I am going to talk about it later in the session. And then also we need to make sure that we're either using group or individual supervised modes linked to falls risk. So you'll see in those algorithms that I showed before, the Australian guidelines and the world guidelines, it sort of discusses, it does discuss when we should be using more individual supervised for more of those high risk, maybe the intermediate risk, moving into groups when they're in a lower risk category. One thing I didn't mention though, and as you know, and certainly as Bilana was saying, that 1 in 3 older adults will fall within the next year in that 65 plus age group. None of our older adults are at no risk of falling. So we must make sure that we are advocating for the right amount of exercise, for the right amount of time, so that we can actually reduce falls within our community. Okay, so this list is offered by the Australian Falls Prevention Guidelines in the community care section. Similar ideas to the previous slide, and I suppose these suggestions that I have here can be used individually, but also to increase the challenge, we can combine them. So for instance, we can sit to stand with a narrow base of support. We can sit to stand and reach out to the side. We can reach and have a narrow base of support. We can step in different directions and reach and look and change direction and speeds, avoiding obstacles, that type of thing. We can walk in different directions with a narrow base of support, like walking in tandem stance or tandem walking, all those types of things. So combining those things together. Now, dual tasking is another thing that we need to make sure that does make it a lot more functional, because when we're doing everyday tasks like washing or showering or cooking, we're not just sitting there standing still focusing solely on maintaining our balance. We're having to think about other things, do other things, carry something. So it's really important that we add cognitive load. We add decision making. We add attention challenges to the person, because these are the challenges that they're going to experience every day. Adding weights. So this is actually quite where I think probably only where those little 1 and 2 kilo weights come into play. Adding a little weight challenge or a can of beans, adding that to the reach, adding it to the narrow base of support and the reach, so that our bodies are actually having to have a lot more postural control, anticipatory control, and reacting to that added weight, to that reach or that movement, that dynamic movement. We also need to include reactive balance training. And I suppose this is one of the things, and it's probably more of the type of thing that we might be including in our lower risk category, and also in that more one-on-one supervised, individualized, I'm here to create those different balance challenges, those unexpected disruptions, and make sure that you're going to be safe. That we're including, that we've taught them all about their ankle strategies and their hip strategies and their stepping strategies. We've taught them those, and then we're introducing some unexpected disruptions in heights of ground, or maybe they're being knocked slightly, those types of things. Really important, because this is the types of times where falls are going to happen. And then also lastly, there's the cognitive motor training such as exergames that was in the Australian Falls Guide. So you may be familiar, especially those that are a little older, will remember the Wii Fit. So that one, you know, making sure that you're maintaining your balance and reacting to different conditions. But then there's also the Clock Yourself app. It was designed by Australian physiotherapists. I remember Meg Lowry years ago giving a presentation. She's a wonderful dynamic physiotherapist, and she, I think, originally created the Clock Yourself app. It's freely available. Basically, it's combining sort of cognitive and physical exercises so that people can improve their reaction time, their coordination, has some impacts on brain health as well. And basically you're using a clock face and different symbols around that clock faces and stepping to and back to the center of the clock to the different spaces. And the really good thing about this is that it's adjustable. And so it actually makes it suitable for all ages and abilities. So get out there and use the Clock Yourself. I should get some royalties. Anyway, all right. Now, this slide is a little bit of a focus of mine. We need to keep in mind that strength training on its own is not effective in preventing falls, that it needs to be done in combination with our functional mobility tasks and our balance challenge. The World Health Organization does recommend strength training at least 2 times a week for the additional health benefits like reducing sarcopenia as we age. There's also improved blood sugar control, better bone health, and there's also a number of metabolic and systemic benefits as well. And I'm discussing it here because there is a tendency to underdose strength training in older adults. And without that adequate load and intensity and progression consistently, we just won't see the strength gains. They won't be achieved. So this is a list of elements that I've taken from the National Strength and Conditioning Association's position statement for strength training for older adults that came out in 2019. And I've got the source in the reference list for you. Now, linking to functional mobility, I've highlighted that we should be using multi-joint exercises that are recommended. So rather than your basic knee extension or knee flexion, so using your quadriceps or your hamstrings, we want to use more multi-joint exercises that really relate a lot more to functional activities that are linked to daily living. So your squats and your split squats and your lunges, those types of things. Now also you can see power exercises are really important because they really closely mimic that sort of reactive balance strategies that we require, like stepping and the hip strategies that we need. And ideally, and this is also comes from the Tiedemann source, the resistance training should be body supported against gravity and should use free weights over machines. So using the free weight rather than the machines. Obviously, in our really challenged high-risk categories, the frail categories, the machines are a fabulous way to introduce some strength training that's more gentle, it's more controlled. But ideally, we should be working towards more body-supported free weights, because these actually are so much more closely related to daily activities, where we actually need to be able to control all the body segments in any plane of motion that might be required for that activity. So if you're in this space of exercise prescription and strength resistance training prescription, I do recommend having a look at this source. So I've got to reverse chaining. striking, as I said, striking fear within the health professional, but often it is a goal that those out in the community want to be able to achieve. Like, okay, I do want to prevent falls, but if I fall, I want to be able to get back up again. I don't want to be stuck there. I don't want to be relying on the ambulance to come. You know, my wife can't help me get off the ground. My husband, my partner, my child, they can't help me. I need to have some skills to be able to get up. So this has been recommended by the Tiedemann article. And obviously you can see there's some challenges to even get started on this activity. You know, if they've got decreased upper limb strength, it's going to be tricky. They may have decreased lower limb strength. And really you can see here that the hips and knees are in a lot more flex positions, which means that the quads, the glutes, the hamstrings, etc., the soleus, the gastrocs, they're potentially in ranges that are a little weaker and much more difficult to kind of generate that force to be able to get up. They might have knee pain or hip pain or wrist pain. They're all factors, and you know, maybe even some hip restrictions. And certainly there'll be some anxiety about getting down on the floor. So it may actually be that we need to address these impairments and challenges first before introducing this. And I suppose that we need to make sure that we express that to our clients so that they understand that and we can work through it. So just to quickly go through, I'm just going to make sure I'm not going to run out of time. I think I'm nearly there. We have, you basically start in your starting position, facing the chair, and then your first step is to go down to half kneeling on a pillow or some sort of support, and then back up again, and down and up, and down and up, and down and up, maybe for a couple of weeks. That's all they can manage, but just working on that until it's relatively easy and they're confident. Only then do we take the pillow away and go to step 2. Always coming back to the start, back to step 2, up and down, and then so on, down to step 3, but always coming back up. And just repeating until that's relatively easy, or at least they can manage it and they're relatively confident before we step down. Okay, so that's reverse chaining. For those of you who may not be familiar with it, that's a little crash course. So when we think about programs that are linked to mobility and balance, the Otago and the LIFE programs are two that are keenly linked to functional mobility exercises. So firstly, we've got the Otago, and this is widely used. Many of you are probably very familiar with it. It was developed in the late 90s. It's been well researched, and you know, the trials that were conducted showed effectiveness of the program to reduce falls, especially in the older adults, so in the 80+ age grade, and would reduce their falls and falls-related injuries by 35%. It's very widely used. It's effective. It's practical, and it's low cost. But there is room for some individualisation in there, and these are some images that I've snipped of the types of functional exercises that they include. There's many more. So next there is the LIFE Integrated Functional Exercise Program. So this is another evidence-based falls prevention initiative. It was designed for older adults. And the thing is, unlike traditional exercise programs where there's set exercises that they might do in a row, certain repetitions, the key to this is actually it embeds those training effects and activities of strength and balance type activities into their everyday routines. They perform during their regular activities like brushing their teeth or standing up from a chair or being in the kitchen or walking down the hallway. There's a few images here that I've snipped. Another element is also that the program recommends embedding extra challenge into everyday life by actually placing regularly accessed items in more difficult to reach positions. Like we tend to make, let's make everything easier for grandma or for our mother or father who's aging. Let's make it easier. Let's carry that thing for them, or let's put everything in a really easy, safe space. But they're not getting that incidental strength and balance and mobility challenge throughout their days. Now, also, if you're interested, Injury Matters does run workshops on both the Otago and the Life programs. All right, so how hard should the exercise be? So there is a tendency, as I sort of expressed, I suppose, in the past slides, that to be overly cautious when we're working with older adults. We tend to create a situation where we fragilize them. We don't challenge them adequately. And then the challenge is then, suboptimal. It's not actually challenging those multiple systems that are required in order to challenge and adapt the systems to be able to deal with unexpected disruptions, to deal with the challenges that they might face, to deal with the low vision or the not turning the light on or the change in surface. So it's really important that we're making sure that they are challenging enough. We need to set up the older person for success and for safety, but always making sure that we are aiming for a moderate to hard challenge. We also must make sure that we just don't hand over some exercises and go, there you go, they're yours for life. That we are reviewing, that we are progressing so that the dosage is maintained for improving and reducing that falls risk. Now, one way to prescribe adequate balance challenge, and it's also recommended in the Tiedemann article, is the balance intensity scale. And this was developed through Monash University by Fairley and her colleagues. Now, this image here is the client self-assessment, where they check off items linked to before they start the exercise and during the exercise, and then they rate their overall effort. Now, this alone shows the client that they should be experiencing things like anticipating how to start, possibly needing a little bit of support or attempts to get into position. And then during the exercise, they may be holding their breath, they may be gripping their hands, they may be puffing, they may actually fall out and use that wonderful stepping strategy or potentially grasping strategies, although we do want to prioritise the stepping strategies. They might be tensing their body. And look, so it is expected that they are doing these things. And if they're not, if they're just getting into position, doing the activity, all easy peasy, it's too easy. Okay, there's no harm in doing it, but it's not actually going to set them up for being stronger, more balanced, and able to reduce falls risk. Now, there is a more comprehensive assessment that therapists use that you incorporate looking at all of these items in more detail. But yeah, I suppose we need to make sure that we are adequately challenging, and I can't underemphasize that. But obviously within the safety of, it's going to be different when we're with them versus giving them a home program, but not making them afraid. Maybe let's make sure that we are providing them with the stepping strategies and the hip strategy, and they understand it and they know what they're supposed to be doing when they're doing these activities, so that they can actually challenge themselves just that little bit more. Now, there is a website about the balance intensity scale at the bottom of this image. You might be able to see in the tiny, tiny writing. But yeah, even if you just Google balance intensity scale Monash University, there's a whole website there with lots of information about it, if you're interested. Okay, I think I've timed it not too bad. This is my last slide. And I really want to make sure that we need to get that message across, that falls prevention is everyone's responsibility. And this is something that's actually been put in the Australian Falls Guideline. We need to get the message out there. Now, Injury Matters, we're doing our best. We're providing information and education on evidence-based falls prevention to our workforce, like with things like today and other workshops that we run. We also target older adults in the community. We provide information and education and ultimately trying to empower the older adults to know what to do and if they need support, where to get it. So we really want to make sure that we are doing that. We also are strong advocates within the state and the community around falls prevention programs and environments that are conducive to improving falls prevention. I think we really need to be educating younger people. Like certainly 65 plus, why wait till we're 65 before we do anything about it? Let's look at our 50-year-olds, let's look at our 45-year-olds. Let's look at the younger people because they're the ones that are actually going to be supporting and maybe educating the older adults that aren't aware, asking those 3 questions, noticing the risks, knowing what to do about it and helping motivate our older adults to do something about it, preparing themselves well for older age so that they're in a really good condition so they're not going to be part of that 1 in 3 statistic. I suppose the other thing is also people like yourselves, everybody working with older adults, making sure that they are educated and empowered to do what is needed. But then also I want to think about other health professionals like first responders, our paramedics going in and often being called to a person's home for a falls related incident, noticing the falls risks that are there, maybe referring on, maybe providing some information, really making sure that it's everybody within that chain that's looking after our older adults to give them the right information. And even down to those that provide support in the home, cleaning, gardening, shopping, that type of thing. They know about this. They're the ones that are in the homes. They can actually be the ones also educating and supporting and motivating their older adults in there, that they're looking after their homes or looking after the activities that they need support with, and knowing, oh, I need to maybe refer this on. I'm part of a system, I refer this on, or maybe I'll speak to their daughter or their son or some other carer about getting some extra support. So I think that's me. Thanks all for attending today. I hope you've enjoyed the session. If you were looking at me waving my hands around, that's pretty much me. I do have an extensive reference list, which is here and here. I also believe that Balana is going to be, as I said, sending out some emails with links to the key sources used for this webinar. And I think that we will now be going on to answer any questions that you may have. So I'm going to hand over to Balana and hopefully mute me a little bit.
Okay, thank you so much, Meredith, for delivering that webinar. If you do have any questions, now is the time to ask them. And in the meantime, while we're waiting for those questions to come through, if you could complete the evaluation, that would be great. I can see that we already have one question. Are there any precautions for getting up off the floor, THR or dizziness, etc.? So I'll pass that on to you, Meredith.
Okay, look, I suppose we've got to judiciously use this strategy, and potentially it may be that I was discussing this with another physiotherapist recently, that maybe we want to teach the first bit. So maybe, or the last bit that we're going to be teaching. So it might be that we get them on a high plinth or a high area, and we teach them okay, we've fallen over, we need to rest, we need to check in that we're okay, that we can actually move okay. We then need to come into that crook lying, then we need to roll over, and we can train those bits, and then working on trying to push into that side sit and shuffle. So it might be that we're looking at that. Just remind me again, what were the issues that that were mentioned as far as being a problem?
THR and dizziness.
Okay, yeah. Look, I suppose again, all of these active movements that are challenging are going to maybe mean that we're going to do them more slowly. We're going to, if we are having problems with dizziness, that we actually have to work through them in a more slow kind of movement. I don't think it means that you shouldn't be doing it at all, but I think certainly you might slow down, you might get them to stop at each point a little bit longer, maintain, get their equilibrium back, and then move back up into the starting position again. So it might be that the transitions are a lot slower and that we're mindful of the dizziness implications of that quick change of position. Okay, any more questions?
Yep. So we have, are there any easy types of classes to suggest, e.g. not for very motivated people to do exercises themselves for all ages, e.g. Pilates or Reformer or yoga?
Okay, so as far as Pilates, I suppose, and yoga, the evidence for those being good for falls prevention is unclear. There haven't been huge numbers of studies done that I'm aware of around Pilates. Around yoga, I think the main study that's been done recently is using Iyengar yoga, and which are a lot of statically held positions, not a lot of flow and dynamic movement between the positions. So that might actually be the reason why yoga hasn't been shown at this stage to be as effective. So being the Iyengar yoga, I think there was some commentary on in that study that there was actually an increase of falls in the random controlled trial done on Iyengar yoga. I don't want that to put people off from doing yoga, but I suppose it may not necessarily be one of those things that you recommend. Certainly, I'm not 100% sure of all of the programs that are out there in the community. There are programs through community physiotherapy services. There's the Prime Movers as well. At a recent workshop, we had some Prime Movers instructors come through. I think the thing is that anything that you're doing that's actually dynamic and movement is really great, but maybe that whole message of the level of challenge and things like the ankle strategy, the stepping strategy, power, strength aren't necessarily in all of the programs. That's why I suppose most of the evidence-based programs are more supervised, semi-supervised type programs. I do also believe that the Tai Chi movement programs are well regarded. They have good impact on falls prevention. I'm not sure whether it's with high certainty that we can say that, but potentially with moderate certainty. So maybe some of the Tai Challenge, more balance related Tai Chi type programs might be good too. If anyone else is aware of any others that I'm missing, I apologise.
Thank you, Meredith. It looks like we are running out of time, so I might just ask one more question. Sorry to everyone if we didn't get to your question. How can a non-health professional start interventions, for example, a CHSP coordinator? What are the boundaries of risk and practice? Can they learn to utilize the screening tools to facilitate referrals?
Okay, yes, definitely the screening tools, are relatively straightforward. I suppose it does rely on you having an understanding about what falls are and how, so basically what I was talking about earlier in the session. And so when you're taking falls history, and then also, I suppose, being able to adequately, if we look at the FROPCROM screen, there is an observation of movement. So being able to see whether somebody is unsteady or not, just being able to ask the questions right is that first screen, asking those three key questions. Then when it goes on to the more comprehensive assessments, it probably does need to be either some training, and support in order to complete those. But I suppose it depends on your organisation and whether they can provide that training for you to be able to conduct the more comprehensive assessments. Then when it comes to actually prescribing the exercises, certainly your most basic exercises from a nursing perspective are probably fine, but I think it possibly does require some training or some external support from those that are more trained in exercise prescription for falls prevention. And that is actually part of the falls guidelines, is that if they're in that sort of more moderate to or intermediate to high falls risk, that they really need those prescriptions done by someone who's trained in that type of exercise prescription. That's the answer.
Okay, thank you, Meredith. And thank you so much for answering those questions and delivering that training. I will now just quickly go through our Stay on Your Feet program and how you can be involved. So firstly, we have a suite of resources that you can use in your workplace and with your clients. If you head to our Injury Matters website, you can find all of our resources available and you can download and print these off for free. We also offer 3 free self-paced online learning modules. The Introduction to Falls Prevention. This will go through what a fall is, risk factors for falls, and how to identify falls risk among older adults. We also have exercise strategies and screening for falls prevention, and this will go through how to assess falls risk, gait, mobility, strength, and balance. And it will go through existing evidence-based falls prevention programs. And we have a new e-learning module, Falls Prevention for Community Aged Care Workers. And this will go through the impact a fall can have on an older adult, risk factors for falls, and the role a support worker has in falls prevention. And now we do have an upcoming Falls Forum on the 18th of November. A WA perspective on the National Falls Guidelines Community Care. We'll go through some insights of the WA Falls Report that was mentioned at the beginning of the webinar, an overview of the National Falls Guidelines and recommendations relating to home safety, exercise and bone health. You can register for this Falls Forum online, or you can join us in person. Thank you all again for taking the time to tune in to today's webinar, and to Meredith for sharing this information. Please connect with us. We're on various social channels, and you can also sign up to our Falls Prevention newsletter and our Community Falls Network. Have a great rest of your day. Thank you.